Dr. Anil Kumar Sapre. Regarding him, he is a senior consultant of pediatric pulmonology, and over the last 35 years of experience, Dr. Sapre completed his PhD training in India, and thereafter he underwent further training in various hospitals, including Kent Hospital, Kent, UK, St. James University Hospital, Leeds University Hospital, Leicester, and Dr. Anil Kumar Sapre also has a fellowship in respiratory medicine, sleep medicine, and bronchoscopy from Great Ormond Street Hospital for Children, London. He is trained in PICU, NICU at Leeds Teaching Hospital and Leicester Infirmary, England. Prior to joining Narayana Health, he worked as a consultant in pediatric respiratory medicine, Leicester Royal Infirmary, Leicester University. His area of expertise are pediatric respiratory illness, asthma, allergy, sleep disorder, breathing and polysomnography, pediatric intensive care, non-invasive ventilation, and long-term home ventilation and bronchoscopy. The key procedure performed by him, that is pulmonary function test for young children from 3 years of age. It is a special impulse oscillometric device. Bronchoscopy for children, including young infants. Skin prick test for allergy testing. And unique skill, that is spirometry, bronchoscopy, sleep, PSG, lung function, advanced life support skill, thoracocentesis and chest tube placement, arterial lines, long line and center line insertion, exchange transmission, and cranial ultrasound. Now, I like to introduce Dr. Anil Kumar Sapre to the main topics he will present, that is idiopathic pulmonary hypertension. It is a basic subject to all pediatricians because during the neonatal period, the most of the neonates, that is from the fetal circulation to the normal circulations, it is a physiological process. But when this physiological process altered by some pathological process, and the cause is sometimes unknown, that we call idiopathic. And this topic is a common to the all neonatologists, and we all pediatricians as well as the pediatric cardiologists should know these subjects very well, because it is very easy to manage, but if not managed well, it is killer disease. So Dr. Anil Kumar Sapre, please, you can share your screen and start the today's topics.
Sir, you can stop sharing, then I can. If you stop sharing, I will be able to share my screen, sir.
Okay.
Just keep it. Go to the Zoom. Share screen.
Sir, are you able to see the screen well, sir?
Yes.
Yeah. I bring warm greetings from Narayana Health City, Bangalore. It is a really big pleasure to share if not physically, at least on online with Madam, who has got such international acclaim, not only in Bangladesh, but across the globe for her sheer hard work, dedication, and commitment she has shown in the pediatric cardiology. Greetings, Madam. So I'll come straight to the topic, that is pulmonary hypertension in children, and predominantly because I, being not a cardiologist but a pulmonologist, the main emphasis is on how we identify how these children doesn't necessarily come to cardiologist, but they come to pediatric generalist, and how we actually identify and manage them, evaluate them. This is actually our Narayana Cardiac Center, one of the largest cardiac center in the world, doing omen services to millions and millions of the children from across the globe. So the layout of my presentation is I'll just give a taster of two cases, followed by I'm going to come to the topic that is pulmonary arterial hypertension, and specifically idiopathic pulmonary arterial hypertension. We'll touch upon etiology, features, how we evaluate, and what are the management algorithms. And this is going to be fairly kind of quick succession. And I would like to focus upon some of the cases we have encountered, and some of them actually are from your native place too. So a 4-year-old child presented with fast breathing going on for 2 to 3 years, dyspnea, poor growth, fatigability, but there were no other systemic symptoms like cold, cough, wheezing, fever, rash, and there was some recurrent respiratory infection, but nothing more than that. It was a non-consanguineous marriage. There was no history of heart disease either in the child or the family. And on examination, what was very evident was pectus carinatum, pallor, slight growth restriction. And what specific evaluation showed was that on systemic examination, pectus carinatum with tachycardia. And we could see that there are visible epigastric pulsations. When we auscultated, the P2 was loud, and auscultation, there was a systolic murmur at the left sternal border. If we evaluated further, the X-ray showed cardiomegaly, and echocardiography showed a mild dilatation of LA, but RA and RV were dilated significantly, with IV septum thin, paradoxically shifted to the left, and tricuspid gradient was significantly elevated, which was 80 mm, and mild echogenicity in the myocardium, and fair degree of LV function. It was initiated in view of functional class 3-4 on combination therapy, and gradually, when he came initially, we saw that there was not only cardiomegaly, but there was also bilateral pulmonary edema. And after diuretics and combination of pH medication, we did see him 6 months later, symptomatically better, fatigue decreased, tachypnea was there. On exertion, he had a dyspnea, and his weight has improved and he's maintained saturation. And the echocardiographic findings, even though functionally his story was he did improve in symptoms, but the echocardiography persisted to show the same parameters. And for cardiology, I don't want to show, here is the tricuspid regurgitation, which we use to calculate the right ventricular systolic pressure and mean pulmonary pressure by using this thing. And this was what we noted, and he had a very characteristic findings of pulsation, his epigastric, elevated JV, right ventricular enlargement causes pectus carinatum, and all those things. Another patient, slightly younger, 2 months old, with hurried breathing, difficulty in feeding, sweating, decreased urine output, and a bit of focal seizures, extremely irritable child. And on assessment, had signs of severe shock because BP was not recordable, and all that we could see is a systolic murmur, hypothermia, tachypnea. We did routine pulse, that is emergency things like intubation, bolus, and ventilation. And we did start on first line treatment. When we did the emergency echocardiography, we found features of RA dilatation. Therefore, we started combination of milrinone and pH medication. However, unfortunately, the baby did have several episodes of profound hypoxemia, shock, and patient eventually succumbed. What I'm trying to highlight here is two sets of cases. One who can be very young in age, who can come in the direst of situation, and the cause is still the same, that is pulmonary arterial hypertension. And on the other hand, a child who comes with a prolonged story of difficulty in breathing, comes walking into your OPD, and you have time to evaluate. However, we need to still approach both of them with the same algorithms. So with this brief introductory two cases, I would like to come to the topic of discussion, pulmonary arterial hypertension. Definition is mean pulmonary arterial hypertension of 25 millimeter of mercury at rest or 30 millimeter on exercise. Recently, the 8th working group on pulmonary arterial hypertension, which convened in 2019, though they said that 25 is slightly too much, we should actually target for 20, but still worldwide, the accepted definition is 25 millimeters of mercury. What is the epidemiology? It's extremely rare when it comes to general practice, but when you are doing a cardiology practice or a pulmonology practice or quaternary practice, it is not uncommon to see them fairly regularly in your practice in day-to-day life. The incidence is 4 to 10 cases per million children, and prevalence is 20 to 40. And out of them, amongst the true cases who have PAH, idiopathic constitutes up to 40%. And amongst this idiopathic or whatever you say, the sporadic, about 20% are genetic origin. And amongst the idiopathic, up to 10 or 20% even may be actually familial with autosomal dominant pattern in majority. And amongst them, this bone morphogenetic protein gene is responsible for quite a significant number of familial and also 26% of these sporadic cases are idiopathic. The median age at the diagnosis, if you take the age spectrum, a significant number of them, we tend to diagnose them at 3 years of age. However, if we study them carefully, there is a lag of a diagnosis versus the start of the symptoms. There is generally a median delay of 15 to 17 months from the age of onset of symptoms and the age of diagnosis. And there is a small difference in the way the children as compared to the adults behave. The disease in children tend to progress more rapidly relative to the adults. That's why it's all the more very important that we identify them carefully and this thing, what you say, initiate the evaluation. However, unlike the adult picture, we have a cohort of children who have transient pulmonary arterial hypertension. For example, a fetus has pulmonary pressure significantly higher compared to the systemic blood pressure. Therefore, the blood is not going in to the solid lung. At birth, there is a significant delay. The opening of the alveoli, drop in the pulmonary pressure, suddenly makes changes in the pulmonary pressure. And if there is a failure of this particular transition because of either stress, asphyxia, or congenital diaphragmatic hernia, or in utero problems to the fetal lungs, then there will be what we call as PPHM. But in our practice, what we see is two common entities, that is birth asphyxia and meconium aspiration syndrome, that are responsible for severe PPHN in newborn. However, the good news is it is transient if properly identified and treated effectively. Diaphragmatic hernias can cause transient. In some children, if it is prolonged if there's persistent lung hypoplasia, there can be a chronic persistent pulmonary hypertension also. Bronchopulmonary dysplasia, with the advances in neonatal technology, we know we have a large group of children with bronchopulmonary dysplasia that not only causes lung, but also the pulmonary vascular abnormalities, which is responsible for PAH. And obviously some of the pulmonary diseases, especially I see day to day in my ICU, have transient PAH. And for flow related PH, for example, if you have a left to right shunt, if you correct that, a VSD at 9 months, by 2 years, when you follow, the pulmonary pressure that was elevated regresses. So these constitute transient PAH. The PAH that is persistent or progressive are due to either idiopathic or heritable pulmonary hypertension. Shunting defects, if you close some ASD, VSD at 9, 10 years, they are likely to have persistent PAH. And chronic pulmonary diseases like interstitial lung disease, cystic fibrosis, sickle cell disease can have persistent pulmonary hypertension. Now, there is a pediatric task force. This is actually a working group on PH, VSPH group, and they convene every few years internationally in either in the ATS or ERS, and they make a different changes in the guidelines. Coming to this latest guideline, this is the way the pulmonary arterial hypertension is classified. They're classified into group 1, 2, 3, 4. Let us just focus for a couple of minutes on type 1. Type 1 is actually idiopathic. Idiopathic pulmonary hypertension, that is 1.1. 1.2 group is heritable. And this is the two main type of pulmonary arterial hypertension I end up seeing in my pulmonology clinic, referred by our cardiology colleagues, believing that whether there is treatable or some pulmonary cause that is actually contributing to this pulmonary arterial hypertension. Drug, especially this anorexic medications used in adult population, phenidates and other things can cause pulmonary hypertension. And there is an entity called 1.4 group, which is called associated PAH, which means it may be associated with connective tissue, HIV, portal hypertension, congenital heart disease, cystosomiasis, and 1.5 is those specific group which is PAH long-term responding to calcium channel blockers. For example, when we do the acute vasoreactive testing, we do see a small subset of children who do respond. However, quite a lot of them are actually transient responder. This particular group belongs to a group of patients whom amlodipine, nifedipine reduces pulmonary hypertension consistently for 1 year. They are classed as long-term responders to calcium channel blockers. And 1.6 belong to pulmonary veno-occlusive disease or capillary hemangiomatosis. These are actually abnormalities, genetic abnormalities of the veins where they progressively keep obstructing, or there is a capillary hemangiomatosis, the capillary of the lung, they cause hyperplasia and cause progressively increasing pulmonary hypertension. And 1.7 is pulmonary PPHN. So now we have dealt upon the first group. Coming to second group, this is what you cardiologists commonly see, like mitral valve disease, left ventricular restrictive disease, valvular disease. And again, as a pediatric, I try to remember type 1 and type 3. Type 1 is idiopathic or associated ones, and type 3 is something that commonly to come to us. But what my personal experience is, in these children who have chronic obstructive pulmonary disease, interstitial lung disease, sleep disordered breathing, hyperventilation, in this, the pulmonary hypertension is modest, number 1. Number 2, it is transient. Number 3, the focus is on treating the primary disease rather than pulmonary arterial hypertension. If you treat the primary disease, and despite that, if the pulmonary hypertension progresses or leads to right ventricular dysfunction, that is the time we start considering therapy for pulmonary hypertension. But otherwise, the whole focus is on treating. For example, I have got about 10-15 children with alveolar hypoventilation. We put them on BiPAP and they are at BiPAP. With BiPAP, the hypoventilation is controlled, nocturnal hypoxemia, carbon dioxide, obstructed airway problems are getting better, and there's symptoms do resolve over a period of months to years. However, there are a group of children called developmental lung disorder. For example, Downs, Noonans, DiGeorge, all these things children can have alveolar simplification and also abnormal pulmonary vasculature. This is responsible for developing, for example, as a pediatric cardiologist, you may encounter newborn with alveolar capillary dysplasia with malaligned pulmonary veins. They have progressively worsening pulmonary hypertension in the newborn. For example, PR on day 2 is 80. When you started inhale nitric oxide and you assess after 3 days, it is 120, 150. That's how the scale of pulmonary pressures rise. And and coming to the last entity, that is developmental disorder. This is the table I have included for those of you who are practicing pediatrics. For example, bronchoalveolar dysplasia, diaphragmatic hernia, Down syndrome, capillary dysplasia with malalignment of the veins, lung hypoplasia, surfactant protein abnormalities. All these are responsible for pulmonary hypertension. And chronic thrombotic type 4 is a forte of you cardiologist, or especially adult cardiology. Is there genetics? Yes, there are lots of genetics that is transforming growth factor pathway, which I told earlier, that is BMPR2 receptor, activin receptor, ALK, and the mutations in these are responsible for endothelial proliferation, uncontrolled endothelial proliferation in the pulmonary vasculature, and there is relentlessly progressing pulmonary hypertension. So for example, this is something I have taken from up to date. You can see the number of mutations that have been identified so far. All of these mutations, quite a lot of them are autosomal dominant. What I would like to just share my experience is, few of the patients who have this kind of pulmonary hypertension, we auscultated their parents. And surprisingly, we found that in some of these families, the P2 was slightly louder in the father or mother. And when we investigated, they have some degree of pulmonary hypertension. So the message is that these autosomal dominant inherited pulmonary arterial hypertensions have variable penetrance, which means in one pedigree, the manifestations may be mild, and the other, it may be severe. For example, you may have a mild, but your progeny may have a severe form of pulmonary hypertension. And if we see, these mutations are responsible for transforming growth factor affection of either type 1, type 2, or other signal transduction molecule that are responsible for angiogenesis in the pulmonary vasculature. And same thing. And it is important to mention that we all, pediatric pulmonologists as well as cardiologists, encounter Down syndrome, and we know very well that in Downs, the pulmonary hypertension is very severe. It could be at birth, that is severe PPHN can be there at birth, and severe pulmonary vascular disease may develop later in these children quite early compared to other normal population, secondary to CHD. And and the mechanisms why Down syndrome have earlier or progressive pulmonary hypertension is because of variety of multifactorial. One of them is lung hypoplasia. Second, decreased alveolarization. Third, peripheral lung cyst. Fourth, there may be double capillary network. During formation, there are some capillaries, once they form a thin valve around the alveoli, regress, and there is a one thin layer maintained. However, if there is persistence of this double capillary network, then it can lead to elevated pulmonary pressure. And we know these mutations result in uncontrolled proliferation of the vascular smooth muscle. And this lead to three main pathobiological abnormality, pathway abnormality. What are those three abnormalities? If, for example, it is a idiopathic pulmonary hypertension or heritable secondary to these mutation, there is relative decrease in the nitric oxide, increase in serum endothelin, and relative deficiency of prostaglandin I2. And these are the three main. The reason I'm trying to say that is our targets of therapy are on these three pathways. For example, increase the bioavailability of nitric oxide by using phosphodiesterase 5 inhibitors, which is tadalafil, sildenafil, or if there is increase in endothelin 1, you suppress it by using endothelin blockers like bosentan, ambrisentan. Or if there is relative deficiency of prostaglandin 1, we do give prostacyclin infusions or inhalers or subcutaneously. So that is why it is important we just remember that. So in brief, this is the pathology that is mentioned in our standard books. Initially there is endothelial dysfunction in our first layer, that is endothelium, that leads to vasoconstriction, and there is imbalance, that is the nitric oxide and Pg, that is endothexin and tranexam are increased, and therefore there is a decrease in nitric oxide Pg1. This imbalance will start causing vasoconstriction. This vasoconstriction, if it persists for a prolonged time, then just next to the intima, the muscularis will start hypertrophying, and the intimal fibrosis will form. And if this persists for a long period of time, they form plexiform lesion, and these low flow states are responsible for formation of thrombosis. And we can very nicely see here intimal hypertrophy, muscular hypertrophy, thrombus at the center, thrombus at the center, thrombus at the center, and you can see the muscular hypertrophy. It is called onion peel appearance by our histopathologist. So what actually happens in children with bronchopulmonary dysplasia? It affects the growth of the lung, function, structure, and therefore the surface area for the gas exchange is decreased, and this leads to decreased hypoxemia, redistribution of the blood, and progresses to pulmonary arterial hypertension. I mean, this is briefly what we are touching on is actually the etiology, the genetics, the classification by the pulmonary arterial hypertension group. And now let us, sorry, is there? Now the clinical manifestations are related to several factors: the age of presentation, the etiology, and the stage of the disease. So that is determined with the degree of pulmonary arterial pressure elevation and status of the right ventricle. In majority of the children, the manifestations are breathing difficulty, exercise intolerance, dyspnea, fatigue. And if the disease progresses, they can have chest pain, discomfort, dizziness, and a lot of my adolescent or older children come with syncope, rarely arrhythmias. Hemoptysis is exceptionally rare. I just seen one or two, but most of them are chest discomfort, breathlessness, syncope. However, if the disease is very advanced, then you can have very classic features of right heart failure with pedal edema, ascites. So when do they present? I have been asked to talk about idiopathic pulmonary arterial hypertension. They can present throughout childhood, even in infancy. However, the majority of the symptoms are age related and non-specific. And what is very common is syncope. Why? Because they're born normal, their heart was normal, their pulmonary system was normal. Because of these genetic mutations, or due to the fact that we don't know, slowly over months or years, the pulmonary pressures are increasing. And these children adapt to a lifestyle that will permit them. For example, they adapt by just being more sedentary for a year or two. But when they start suddenly playing because of peer pressure or whatever, they start experiencing symptom, which is fatigue, difficulty in breathing, exercise intolerance. And if the right ventricle start failing to the extent that there is inadequate flow to the LV, and therefore left ventricular outflow falls, they can start feeling syncope. Syncope is initially exercise related. Subsequently, it can manifest at rest also. This thing. However, that is very common. And as a pulmonologist, very interesting to see that quite a few of these children are diagnosed as asthma, because dilated pulmonary arteries do cause some degree of compression of the airway, and not only they have breathing difficulty, they have some noisy breathing. And one doctor just auscultates and says that there is some wheeze, a child is given some nebulizers, he feels temporarily better, and it is actually mislabeled as. So we need to carefully auscultate, make sure that all the symptoms of asthma, that is wheeze, chest tightness, persistent cough, which is more in the night time, are present, to exclude that it is actually not asthma but PAH. And isomangarization, I know cardiac causes I don't want to touch, lung diseases I have mentioned. And coming to examination, we see that paracardiac heave, which is right ventricular lift, palpable P2, loud P2 on auscultation, ejection sound, and diastolic murmur of pulmonary insufficiency can be there. And this is the investigation of pulmonary hypertension. What we do, ECG, we do echocardiogram, and sometimes if there is some suspicion about connective tissue diseases in the form of cutaneous joint manifestation, we do ANA profile. Commonly, if there are respiratory symptoms of asthma, OSA, I do pulmonary function test. Sometimes, but not sometimes, more often in children who have got idiopathic pulmonary arterial hypertension. That is, we have taken a thorough history, but we are not able to identify a specific mechanism for PAH. We end up doing CT chest with vascular component, that is angiogram, and that gives us quite a many times anomalous pulmonary venous return, partial anomalous pulmonary return, scimitar syndrome, pulmonary vein stenosis, sometimes pulmonary veins draining into azygos, sometimes draining into sinuses, and all forms of abnormalities can be identified by CT chest as a secondary cause of pulmonary arterial hypertension. And I don't want to talk to the cardiac PGs about this. This is what you do every day to measure the pulmonary pressures. And coming to blood test, the pro-BNP has become one of the important tools in assessing the severity of the pulmonary arterial hypertension. Even the recent guidelines on risk stratification use uric acid and brain natriuretic peptide. If it is normal, we can to fair degree say that we are dealing with a mild to moderate patient. And if it is significantly elevated, we know we are dealing with a functionally advanced disease. Functional assessment is possible in children who are 6 years and above by using 6-minute walk test. MRI is a good tool, and however, the standard test is catheterization. The reason, it measures pulmonary pressures, it also calculates vascular resistance. If it is less than 1.5 vascular Woods unit, we know we are dealing with a normal pressure. If it is elevated beyond 3, we know we have got a pulmonary arterial hypertension. It also helps in identifying cardiac output. If we are dealing with a child who has got output of 2.5 units, 2.5 liters, brilliant. If the output is less than 1.8, we know we are dealing with a child who has got very advanced pulmonary arterial hypertension. Catheter, there is a test called catheter, what is a pulmonary vasoreactivity. In that, a vas cath is placed in the pulmonary pressure and inhaled nitric oxide 40 to 60 parts per million is given. And then if there is a decrease of pulmonary pressure by more than 10, then it is suggestive of vasoreactivity. And if vasoreactivity is there, this small subset of patients are treated with calcium channel blockers like nifedipine or amlodipine. And this is what still now what I have mentioned. It is a good from European Respiratory Journal 2019. Those of you who are taking, you can take a photograph of this particular slide. The reason I say that is it just summarizes how to algorithmically approach these patients with whether to label them first, exclude respiratory diseases by doing pulmonary function test, polysomnography. If lung tests are excluded, and the first step obviously is ECG and echo. If you do not have a structurally abnormal heart, then look for lungs. If there is not lungs, then look for any perfusion ventilation mismatch and so on. That is a good tool to look at the algorithmic approach. And this is New York Heart Association classification. And unfortunately, to the postgraduates I'm speaking to, what I would like to say that lot of children come at actually New York Heart Association classification step 3 and 4, which implies these children have very advanced disease like right ventricular failure at rest, dyspnea, and fatigue. And McLaughlin in 2006 has devised a very good prognostication category, that is low risk category, where the prognosis is really good. For example, they do not have features of RV failure. They have 2 or 3 World Health Organization functional class. If they are able to 6-minute walk distance in adults more than 400, and in children if it is more than 360, brilliant. However, it is less than 280 in children. That means in 6 minutes they are not able to walk for 280 meters, highly suggestive of very advanced disease. Cardiopulmonary exercise test, we have got this machine, but it is cumbersome. And if we can use the oxygen utilization, if it is more than 10.4, it is good. If it is less than that, and what you people are interested is actually echo. If the RV dysfunction is minimum, we are looking at a good prognosis. If the patient already has pericardial effusion, which means the atrial pressures are very high, RV is enlarged, dysfunctional, fairly contracting, septum is moving and bowing into the left ventricle, the filling of the left ventricle is affected, then we are dealing with a child who has really advanced disease. And BNP, as I mentioned, if there is mild elevation, it belongs to low risk, and if it is severe, then it is a bad prognosis. Same thing. So how do you treat them? If they come to emergency, oxygen, Lasix, so rarely anticoagulation, and infection prevention. So, for example, how this is another slide. Those of you who are interested, I would like you to kind of sorry. Those who are interested can take a photo of this. So what it is basically saying is, if the acute vasoreactivity testing is positive, you can try calcium channel blocker. However, our personal experience in Narayana is that we are not doing catheter studies because the children who are coming is already in stage 4 disease. However, if you do, then you can identify a small group of patients. Then we identify a group of children, either low risk or high risk. For example, low risk are those who have got moderate RV dysfunction. Then we try endothelin receptor antagonist, which is Bosentas or sildenafil. Now the new drugs in the basket are inhaled prostacyclin agonist. Some people upfront start one agent, some start 2 agent. But what the science, the latest evidence is, combination therapy is better. However, a child has come to you in severe form of the disease, then we have to use epoprostenol. For example, for those of you who are doing your post-graduation, I would share my experience with epoprostenol. In United Kingdom, we have a transplant center in Great Ormond Street Children's Hospital. We have enrolled, we in the sense, in the past when I was doing my training there, we have children enrolled with severe forms of pulmonary hypertension. When they have oxygen dependence at night, breathing difficulty at rest, oxygen requirement, and severe RV dysfunction, they are not able to do any form of physical activity. That means it is an advanced form of pulmonary arterial hypertension. In that group, a Hickman line is inserted, that is a permanent central line, and epoprostenol is initiated, which runs 24/7. And this epoprostenol is given continuously for a period of time with the hope either pulmonary pressures drop to some extent, or in majority of the cases, it is as a bridge for bilateral lung transplantation. If those therapies are not available, or if the child has significant, what do you say, syncope, life-threatening syncope, then to reduce the right ventricular dysfunction and what you say, decompress it, you can use atrial septostomy or Potts procedure to decompress the right ventricle. Some of these children do feel relief of the symptoms of syncope at the cost of developing cyanosis and other things. But the definitive therapy in majority of these children is lung transplant. So this is just the algorithm of how we approach. Let us talk about each of these medications. Thank you. And prostanoids, I would not like to go too much into that. I just mentioned half-life of it is very small. That is only 2 to 6 minutes. Therefore, it has to be given through a permanently inserted intravenous therapy. And if you have a world-class World Health Organization functional class 4, then it is the first line of treatment. Unfortunately, the problems are they are dose dependent, there can be side effects, and abrupt cessation because of either line clot or any problem can cause sudden death in these children. Therefore, the researchers have identified prostacyclin analogs, like especially treprostinil, that can be administered subcutaneously, and the half-life of it is 45 minutes. And unfortunately, that has to be given very frequently. Next is inhaled prostacyclin, and this is epoprostenol therapy, and these are lots of papers. This thing I don't want to go, those of you who are interested can go through those. Second thing is inhaled alloprost. Again, the cost is prohibitive, available only in few centers in the world. Third thing is endothelin receptor blockers, and they belong to, endothelins belong to a family of isopeptides that contains 1, 2, 3, and endothelin 1 is a potent vasoconstrictive peptide, and that is primarily produced in the vascular endothelium. And what we have is these blockers, endothelin antagonist, bosentas. And for example, in last 10 to 15 years, we have used bosentas in a significant number of children, and concomitant use of bosentas have allowed for a decrease in the epoprostenol dosage and associated side effects. And even in some children, it has allowed for discontinuation of epoprostenol in some children. What is the evidence? There are lots of paper, survival with first line bosentan in patients with pulmonary hypertension way back in 2005, and subsequently there are lots of papers in several journals, and survival estimates were 96% at 12 months and 89% at 24 months. So these endothelin blockers have really changed the game in the management of pediatric pulmonary hypertension. And this is the another paper. And what is the meta-analysis saying? The meta-analysis of Basentas is that these endothelin receptor antagonist is increases the exercise capacity, improve functional class, reduce dyspnea, and also improve the cardiopulmonary hemodynamic parameters. Coming to the next molecule, that is phosphodiesterase 5 inhibitor, and that is oral sildenafil. There were a lot of studies there about it. How does it work? It causes vasodilatation by nitric oxide and cyclic guanyl phosphate pathway by exerting anti-proliferative effects. And therefore, in these studies, similar findings, that is improvement in hemodynamics, exercise capacity, has been seen. So what are the choices of agent according to WHO? For example, this is what we just earlier mentioned. This is the same what you say slide, but this was a WHO consensus on 2013, and in 2018, when this World Symposium, what you say, sat together, the treatment modalities are almost similar. In lower risk group, the drug of choice is either Bosentas or sildenafil or others in the USA. And if it is moderate, then you can use combination therapy. In the higher risk group, epoprostenol, unfortunately not available in our part of the world, or combination therapy. So in children with idiopathic pulmonary hypertension, if it has progressed to severe life-limiting stage, that is their oxygen dependent day and night, functional class 4, cardiac output is low, they are having life-threatening pulmonary hypertensive crisis, then they are listed early onto transplant, and bilateral lung transplant is the only curative treatment for advanced severe forms of pulmonary hypertension unresponsive to medical management. And the 5-year survival of children who have undergone transplantation is up to 50%. So these are the classification. These are the guidelines for referral. If your cardiac index is low, pulmonary pressures are high, and rapidly progressive disease, you need to refer to the center. In our center at Narayana Health Center, we have transplanted more than 10 patients, both heart and lung, for variety of the condition. And our expertise in the area of transplantation is growing. We have a dedicated heart-lung transplant team composed of pediatric pulmonologist, cardiac surgeon, thoracic surgeon, and this is going to be the future for a set of patients who are in reasonably good health but progressive disease. Up to this, there are newer medications I have not touched. I would like to tell a few more things. For example, studies. In 1999, there came a study of survival. The survival was only 10 to 20% at the end of 10 years when drugs were not available. Then subsequently a study came on single drug therapy and follow up for 10 years. The survival was 60% on monotherapy and 80% on dual therapy. That means double therapy was far superior compared to single. This year, the Triton study that came out shows use combination of 3 drugs. Unfortunately, it was not a positive study. So, but still for a limited patients who have severe disease, we can use triple therapy. Sir, till now I have covered the theoretical background. If you give me another 5-10 minutes, I can share the cases that we have seen in our center. Is there time or you're done, sir? Madam, are you?
Please continue. It is our pleasure to show you.
Okay, sir. So kind of you. Thanks a lot. I would like to highlight the cases that are there. For example, this was a child, 3 months old child, hurried breathing, noisy breathing, non-spontaneous wedding, mild tachypnea, loud P2, liver was 2 centimeters. We started the combination therapy, and within the follow-up within 6 months, child recovered. What we can derive from this particular child is there was some stress at the time of birth or subsequently. Child pulmonary pressure never regressed, and therefore during the follow-up with combination of this therapy, the pulmonary hypertension improved. So for example, you can see at admission the echo showed all these things, RARB dilatation with the gradient of 80. However, 6 months later we saw none. Another child, 1-year-old child, hurried breathing, irritability, tachycardia, tachypnea, seizures. When we assessed, there was loud P2, and we can very well see that the main trunk of the pulmonary artery is dilated even on the X-ray. And he was started on therapy, combination therapy. When we saw him 6 months later, child was symptomatically much better. However, his tachypnea, though decreased, echo was persistently showing dilated RARV with pulmonary hypertension. He is probably, we did extensive workup for HIV, coagulation profile, ANA profile, echocardiography, infant lung function test, not infant lung function test, lung function test, OSA. We couldn't find any primary etiology for that. And we also sent the whole clinical exome. Unfortunately, we could not identify any familial form of or heritable forms of genetic mutation. So he belongs to a group of idiopathic pulmonary hypertension and will need long-term therapy and follow. We have another girl, Samruddhi, 4-year-old child, presented with recurrent episodes of unresponsiveness. You can just see this child, the video, and you can imagine. Parents reports her, she is breathless with routine activity, frequent episodes where she is going blue, dusky, unresponsive, and whole body turns blue. She is perspiring, moaning, grunting, and we witnessed 2 episodes within our OPD practice, and we were seek the parents approval to video this and just show. And we can see that this is a case where the X-ray is showing hugely dilated cardia, and the CT is showing dilated RA, RV, and there was a thrombosis in the right internal jugular vein, and these were the findings. We were trying to see if there is any lung parenchymal disease, we couldn't find, and echo showed the same thing. And we just had a long chat about the very advanced disease, and we did start the medications. Another child, breathlessness. He is now 1 year, 9 months. His symptoms started at 1 year, and you can just see that similar symptoms of similar symptoms of breathlessness, recurring cyanosis, difficulty in breathing, facial puffiness, and progressive disease, suggesting right ventricle has already failing, causing severe pulmonary arterial hypertensive crisis. The crisis is characterized by sudden increase in pulmonary pressure. The RA, RV, which are already dilated, further dilates. This dilated RV pushes the septum of the LV to the left, and there is no cardiac output from LV, and there is no forward flow. Therefore, they become progressively cyanosis. And once the hypoxemia worsens at its or reaches its peak, they tend to lose their consciousness, become unresponsive, and can look like encephalopathy. Some may have even uprolling of the eyes, defecation, and this whole crisis, if not identified and treated effectively with combination of diuretics, fluids, sedation, oxygen, can be life-threatening. They can have palpable liver. The larger the liver, and in this child who had cyanosis, we were just seeing the JVP, and JVP was touching the mandible. Not very well visualized in this video. So ECG shows P pulmonale in lead 2, and then we can see that the left-sided chest leads, that is V5, V6, shows deep S waves, and echo confirms the same findings. And to the august audience who are being trained in pediatric cardiology, I don't want to show a great deal, but amongst these children, the pulmonary artery, when you compare to the size of aorta in cross-sectional imaging, you can see it's almost significantly dilated pulmonary arteries. A recently seen child, 7 years, with swelling of the eyes, hands, feet, difficulty in breathing, and periorbital swelling. This swelling, which was initially confined to the upper half of the body, progressed to the whole body with pedal edema, reduced appetite. And the background in this particular child was, I've been seeing this child since early childhood, and his problem was initially he had chronic respiratory symptoms. And if you see this particular diaphragm on the left, the diaphragm is not visualized. suggesting that there is left lower lobe atelectasis. During the follow-up, his respiratory symptoms worsened and he had a mediastinal shift. And if you see this, this is the right lung which is herniating into the left hemithorax. The mediastinum is shifted, suggested by whole of the trachea, both upper and lower trachea are shifted to the left, and the whole of the left lung is just a nibble of tissue, completely atelectatic. So we had a multidisciplinary team and we decided that this lower lobe, which is completely atelectatic, is probably contributing to persistent symptoms. We underwent in 2018 left lower lobectomy. This is post-op X-ray, and after lobectomy, this was the X-ray. The mediastinal shift was slightly less, and the left upper lobe to some extent was there. However, 2 years later, he came to us now with very frank features of right heart failure, characterized as mentioned in the history of puffy face, pitting edema, duskiness, low saturations, sternal deformity, and this is how he looks now. Pectus carinatum, then sort of deep growing, probably Harrison sulcus, and very protuberant chest. So these are the X-rays. Again, the ECG and the echo suggest that there is severe pulmonary arterial hypertension. Is this idiopathic? Answer is no. This is actually class 3. That is due to chronic lung disease. This child had persistent hypoxemia, probably nocturnal. There was mediastinal shift. This mediastinal shift was responsible for probably hyperventilation, hypoxemia, and over last 2 years, he has developed severe pulmonary arterial hypertension, unfortunately. And with our best intention, we removed his left lower lobe. But to our surprise and bad luck, he has developed a right ventricular dysfunction secondary to severe pulmonary hypertension. So I have got at least 5 to 6 cases of complete atelectasis of left lung, and I've been following them up for years. And I ask them annually to check the pulmonary pressures. Most of them it is fine, but few in whom there is hypoxemia, they can progress to pulmonary hypertension. This is the another child showing same features. Another child who had respiratory failure, poor sensorium. We has to intubate, ventilate, and after ventilate, we found that the RV was so huge compared to the LV. So these are all the interesting cases. At the end, I would like to just before I conclude, I would like to bring to your attention few of the interesting cases I have seen in my practice, and I will not take more than few seconds to highlight about them. Just give me I don't know whether this particular entity prevails in Dhaka. I'm not sure, but I thought at this juncture, I would really like to highlight this because I'll straight come to the topic of 4 or 5 cases I have seen. Please focus on this particular this thing. I was presenting this particular data a couple of years ago about our experience. I would like you to guys, who those who are postgraduate, to focus that between two months to 1 year, we have got these children who are exclusively breastfeeding. And all these babies are born at term without any problem. Their weight was good, no neonatal complications, no. They presented with difficulty in breathing, irritability, shortness of breath. Some children, sir, yesterday he was very irritable. Today voice is not coming. I can see the muffling of the voice. When you examine the child, he's grunting, cyanos, poor perfusion, shock. And when we do the echo, we find that there is severe PAH with RV dysfunction. And I would like to emphasize that the common thing in every case of this pattern we saw is the mothers were taking exclusively polished rice with thin rasam. Rasam is a word that we use for dal, which is thin dal. And the tradition in some parts of the Karnataka or South India is that after delivery, to for some beliefs, they only give the mother this polished rice and this rasam. This is deficient in vitamin B1, that is thiamine, and this thiamine is deficiency is responsible for wet beriberi or infantile beriberi, or also called as thiamine responsive pediatric pulmonary arterial hypertension. And our experience subsequently, after I have presented that data, we have identified more than 20-30 patients. Within hours of, let us say, administrating intravenous thiamine, the child shows improvement. Some children have shown improvement of recovery of shock within 2 to 3 hours. I was not initially believing myself, but we gave IV thiamine. The child who was pale, dusky, grunting, moaning, transformed into pink color, duskiness improved. So it's a remarkable activity. So amongst the infants who are young, please keep a possibility of thiamine deficiency. And why thiamine is what you say is important is it is responsible for the what you say. I'll just highlight here. The thiamine is responsible for thyrophosphate, which is one of the main co-factor for mitochondrial function. And whenever there is mitochondrial dysfunction, the pulmonary pressure and encephalopathy ensues. And you can find out a lot of what you say literature on thiamine responsive this thing. How do we treat them? We treat with intravenous thiamine 100 milligrams once daily for 3 days, and within 24 hours when you do echo, you will see that there is remarkable decrease in the pulmonary pressure. And in lot of the children who are actually thiamine responsive, 48 hours later the pulmonary pressures are normalized, almost normalized. Even if they were 100 and they were gasping, intubated, within 24 hours these babies have extubated. So that is, and after 3 days we change them to 10 milligrams once daily of thiamine. So this is our experience. I thought I will just share with you. Actually, is it actually a new disease? Answer is no. As early as 1961, CH Captain has reported actually 4 cases similar to what I have reported. And in 2010, from Kashmir, they reported 55 infants with similar. And now at our Bangalore, there is a center called Jayadeva Institute. They have reported 250 cases. And I was actually, after meeting a cardiologist there, I was enlightened about this entity, and subsequently I started diagnosing a lot of these conditions. So it is not a new disease per se. With advanced technologies, easy access to the latest modalities, we are now started to recognize early, treat them better. Thanks a lot. Really thanks a lot to the team at Bangla who has given me this opportunity to share my experience, little bit of my experience, and speak to you. Thank you.
Thank you. Thank you so much. Thank you.
Madam,
Doctor,
is there anything you do differently you would like to share your experience? I would be delighted to know, ma'am.
Question, and I can say something in response to our Anil Kumar's great lecture on his lecture. Mofazzal.
Thank you, sir, for your nice delivery. It is the last experience, what you have said. In our practice, our people used to consume the mini cut rice. That is the original form of rice, cut the surface and turn into fine rice. That is the adverse effect we can trace this child because most of us, that is those who are living in the cities, they used to take this type of rice, what you have said. In Karnataka, they are used to. Original rice turns into that is fine rice. That they like to take basmati, as the basmati is so much costly. They used to take it as a alternatives to basmati. But these things could be adverse effects to their children, but we are not aware of this. So we took with the pediatricians or physicians, neonatologists, all should observe this child, those who are presenting in the infant period or in the later part of the life, suggesting that some of the child presented such like bronchiolitis. They think it is a common seasonal disease that might be a form of persistent pulmonary, that is the idiopathic pulmonary hypertension. Could be due to the vitamin B1 deficiency.
Yes.
If you look for that, we can find. If we not look for, we could not identify these cases.
Entirely agree with you, sir. That's
Yes.
so. So when over
Okay, Mufazzal.
Madam.
Hello. Mufazzal,
Madam.
are you listening?
Yes, I'm
okay,
listening.
We are actually going to, we are going to close the session because it's more than 1 hour. I have seen Ashfaq asked a question about the lung biopsy to Dr. Anil. So if Dr. Anil can answer this question, then I will give my conclusive remark.
Madam, lung biopsy is rarely used in the diagnosis. If we have if the CT scan is suggestive of interstitial lung disease and we are not sure about the nature of the disease, lung biopsy is used. We had 2 cases of pulmonary veno-occlusive disease, siblings. One sibling died 5 years ago at the age of 17 with relentlessly progressive pulmonary hypertension. I did the lung biopsy. His brother, who was that time 10 years, now at the age of 16 years has come up with PAH. So we do lung biopsy in children in whom we suspect there is a chronic lung disease, and the nature of the lung disease is not clear with our CT scan or X-ray. To diagnose them, to see if there are targeted therapies, we do lung biopsy. But in pulmonary arterial hypertension per se, there is no role of lung biopsy.
Thank you.
Thank you, ma'am.
Thank you, sir. Now, your lecture was so much actually diverse, and you have touched so many points that I don't know from where to start. But I just want to start from your very points, your observation and analysis in the cases. We had similar cases, and everybody was thinking that patient will die on that day. But we just gave 1 dose of injection thiamine. On next morning, we came to round and we found he was playing. So the patient everybody was thinking that he would die. But the thing is that was dilated cardiomyopathy. So we find this patient as a case of dilated cardiomyopathy along with pulmonary hypertension. So we give emphasis on the dilated cardiomyopathy, and in our area, for every case of dilated cardiomyopathy, we can't do the vitamin B1 level, but we assume that there might be associated vitamin B1 deficiency. So in every case, we use vitamin B1, Berin, or whatever is available, and carnitine. So for every cases of dilated cardiomyopathy, even if we know that this is due to viral myocarditis, even then we add them for the benefit of doubt. And dilated cardiomyopathy patient in
Madam, you're frozen, madam. Your screen is frozen, madam.
I think the internet speed is slightly slower. That's why.
Especially breastfed infant, and also everybody should think for research finding that So we were thinking that this patient may not respond because these are too high pulmonary pressure, but surprised we used sildenafil after 1 month when they came for follow-up. By the time they were more than 1 month, and was the reason, but only I did the echo and I gave the management, but later we found that channel blocker. You said that in the sometime use like AC inhibitor, enalapril kind of drugs, but I don't know whether you are using this. But AC inhibitor is also not bad. Some of the cases we are using enalapril, like ramipril kind of thing, and also of course calcium channel blocker. About one of your cases, firstly you showed two of your cases. In your first case you said LA and RA was dilated. So when LA and RA is dilated and LV and RB is small, we sometimes think about of restrictive cardiomyopathy associated with severe pulmonary hypertension.
Yes, ma'am.
So just I was just wondering whether it was a kind of restrictive cardiomyopathy or not. About your first one,
Yes, madam.
Dr. Ronil.
We had the discussion in our cardiology team, and they were debating the most likely amongst the cardiomyopathy. We know the restrictive is the rarest one. Both the diagnosis is also rare, is difficult. Managing is much more difficult with this group of children. So it was thought about that.
Yes.
Because the pulmonary pressures were very high, we thought that the LV diastolic dysfunction may be driving contributing to the pulmonary pressures. And because the LV is diastolic dysfunction, there LA is dilated, and therefore the back pressure is leading to possibly pulmonary hypertension. Yes, ma'am.
Yeah, thank you. And about the drugs, do you have inhaled iloprost or like subcutaneous? You mentioned about treprostinil.
Madam, epoprostenine is the drug that is routinely used in European centers and US, and that is used via Hickman line for those children who are class 4, class 5 functional dysfunction, and where the contemplation is that we are waiting for a lung transplant. However, after the invention of bosentan and other things, sometimes if you give 6 months of bosentan, trelipastin, all newer phosphodiesterase inhibitors, tadalafil, the need for epoprostenine has come down in some children. But however, with advanced disease, they invariably need transplantation. It is not something that is available in our part of the in our country. It is used both in Europe and America.
Yes, I know that, because this drug is so much expensive also. We can't continue, like his half-life is only few minutes, and we can't continue as a continuous drip for 24 hours. So we never tried that because we know that we will not be able to afford that. So I think that's all. And about the transplant you have mentioned, and in the neonate actually we are using, like I was forced actually to use this like sildenafil, bosentan, without knowing that whether these are good for neonates, whether these are contraindicated, because we were undone. We are not getting any actually to give them and to cure them. These drugs since 2000, this sildenafil, and everybody was like my seniors, like the people who are too senior, they were scolding me that why are you using this drug without knowing. I was not getting anything in the literature, but I was undone. I had to do something at that time. So I was using and I was getting very good results. Yes, now I am seeing that in the guideline, they are using this.
You are absolutely right.
So what is about your experience?
Same, Same with us. We encounter a lot of children who had perinatal depression. They have profound pulmonary hypertension. You start inhale nitric oxide, some respond, some don't. But when we are faced with refractory shock, severe pulmonary hypertension, just like you, we have started IV sildenafil, continued nitric oxide. We have given Bosentas through NG tube and and um, and just gave some Milrinone, and 48 hours down the line, game is changed. The RV improves, the shock improves, the pulmonary hypertension response, and then, I mean, if you talk about pure science, do you know whether these medications work or not worked, or it is just a spontaneous recovery? It is difficult to prove or disprove. But in the dire situation when PPHN sometimes can be so nasty that relentless hypoxemia can kill unless you have a ECMO at your center. So sometimes before being on ECMO, we have put all these medications, and by the time we thought that we'll put on ECMO, we saw that the FiO2 started improving, saturation started improving, and we just managed on this combination of medication. Within 24 hours, slowly the FiO2, the PEEP, everything start recovering. Answer to your question means our practice is also same. Sometimes we are faced with these children. I got one child whose name is Ahan. Right now he is in my ICU, ma'am. He presented with life-threatening PAH 3 times. Every time he intubate, ventilate. He's on everything: sildenafil, ambrisentan, risuagat, lacilactone, digoxin. But still he is getting a life-threatening events, and he's getting. So in such circumstances, I think we have to use combination that is available and wait for the science to emerge and tell us that the centers which are doing randomized controlled trials, the utility or futility of these medications, and time will tell us. At the moment, when we are pushed against the wall, we are using all the medications that are available in the basket, madam.
Yeah.
Don't know whether it is right or wrong. That is the approach.
Yes. Yeah, but this is an evidence also. So medicine is evidence based.
Yes,
so we are getting some result. These are the evidence. So maybe on some day this will come as like in the control in MCT trial. Maybe this case will come and they will be included.
Yes,
Thank you, doctor. Thank you so much. And it was very nice delivery, and we learned many things from your lecture. Actually, maybe we'll take another lecture from you another day on the drugs and your experience on using these drugs. Thank you.
Thank you, madam.
Thank you, sir.
You can.
Thank you, sir. Thank you for the nice and well experience, as well as the new era of this thinking, that we can think that this might be a case of alternatives to breathlessness that might be comes from the pulmonary vasculature.
Sure.
Thank you.
Thank you
very much.
Thanks a lot. Thank you.
Thank you, Dr. Anil Kumar. Thank you, everyone. Thank you, Beximco, and thank you, Mr. Shubhabroto, for helping us in taking this lecture. And thank you, students, for attending. Thank you.
Thank you. Thanks, madam.
Thank you.